Let's take a look at some respiratory disorders. Those respiratory disorders when individuals are not able to produce a normal breathing pattern. It's referred to as periodic breathing. Periodic breathing is when we see bouts of decreased ventilation and increased ventilation. And generally, these are different forms of apnea that arise, where to some extent the body can then attempt to compensate. And we go from periods of cessation of breathing, stoppage of breathing or decreased breathing, followed then by overcompensation and increased rate and depth of breathing. A good example of that is the Cheney-Stokes form of breathing, which is a type of brain trauma to the respiratory centers, oftentimes due to stroke, where the respiratory drive is turned off temporarily for just a few seconds. And since the individual is not ventilating, CO2 levels rise precipitously. And then finally, the very high levels of CO2 turn on the drive to breathe with force. And so in an individual with this type of breathing pattern, we would see alternated shallow breathing with overbreathing. And it can occur while awake, and it can also occur while asleep. So it is a form of central sleep apnea that we would categorize it as if the individual had this issue while they were sleeping. Another disorder that involves cessation of breathing, where there's respiratory arrest during sleep. This is referred to as Ondine's curse, or Ondine's curse, sorry. Ondine's curse, more accurately, is known as congenital central hypoventilation syndrome. And it is a genetic disorder likely linked to mutations in the FOX2B gene. The FOX2B gene is important during early development of the nerve cells in the neural crest. So if those nerve cells that are part of the breathing center do not form appropriately during early development, it could lead to these issues with being able to appropriately control breathing rates, especially while sleeping. And there's lots of other issues that arise for individuals that have this particular syndrome as well, many of which are variable depending on the extent of the mutation. Given that the neural crest is important for much of the spinal and brain development. It was thought to be quite rare until more recently. Originally, what I have on the slide is 400 sufferers known worldwide. Taking a closer look, there's at least 1,000 confirmed cases of children with CCHS right today. And it's thought that with more extensive genetic screening, there's probably many more cases that have gone unidentified due to the fact that this respiratory arrest occurs during sleep. For the most part, it's not as fatal as it once was, especially for individuals that have been screened and are being treated appropriately, knowing that this respiratory arrest can occur while sleeping. In terms of another type of sleep apnea, what's referred to as central sleep apnea, which is sort of a catch-all for issues where there's improper production of action potentials. To the respiratory muscles that control inhalation during sleep. Cheney-Stokes breathing, for instance, will fall into that category should that issue arise while sleeping. So central sleep apnea is something I noted here. Central sleep apnea can arise for a variety of reasons, whether that be the damage to the brain, as we see with Cheney-Stokes breathing, or a neurological disorder. Congestive heart failure can lead to issues with the brain responding appropriately while sleeping. In particular, if the individual has pulmonary edema, fluid buildup around the lungs, it begins to mess with certain types of receptors that are responsible for controlling increases and decreases in breathing rate. And especially in the supine position while sleeping, it can have issues with being able to regulate the action potentials that control the muscles that allow for inhalation while sleeping, and effectively lead to cessation of breathing while sleeping. Kidney failure, if the problem with the kidney, for instance, is chronic metabolic acidosis, where an individual cannot appropriately secrete acids from the renal tubules. The compensatory mechanisms that an individual would use then would be hyperventilation, given that it's a metabolic problem and not a respiratory problem. Hyperventilation, which could lead to hypocapnia, low blood CO2. And that low blood CO2 can lead to hypoventilation while sleeping, effectively relaying the message to trap more CO2 and potentially leading to cessation of breathing. With central sleep apnea, snoring is not common. Central sleep apnea is different than obstructive sleep apnea, which is much more common in individuals, and it's caused by obstruction of the upper airway, physically obstructing air moving while sleeping. And snoring is very common in obstructive sleep apnea. In terms of how our medulla oblongata breathing regulatory center responds to input, it's important to consider the fact that under normal conditions, we're using rising levels of CO2, high partial pressure of CO2, as the major stimulus to ventilate. In between breaths, CO2 levels begin to rise. And as we pass that 45 millimeters of mercury, right, high end of our normal values for partial pressure of CO2, then we trigger ventilation, we trigger inspiration by the dorsal breathing center, right, or breathing group. If those levels are fairly high, it might lead to dyspnea, air hunger, something that naturally occurs if you've been exercising, say, and you're out of shape, right? That increased metabolism, increasing the partial pressure of CO2, might lead to labored breathing, shortness of breath, until you are able to regulate the partial pressure of CO2 appropriately once again. If an individual, however, has problems with chronically high levels of CO2 within the body fluids, chronic hypercapnia, especially paired with respiratory acidosis, the high levels of CO2 leading to a low pH within the body fluids. The issue being caused by problems with the respiratory system. Here, in an example like chronic bronchitis, an individual would be hypoxic, they would be hypercapnic, right? Likely have respiratory acidosis. And that individual would become dependent on those peripheral chemoreceptors to help drive inspiration. But those peripheral chemoreceptors are most sensitive to the plasma concentration of oxygen. This occurs because the central chemoreceptors, they can become desensitized over time if those levels of pCO2 remain high. Then what arises are problems with giving an individual that has chronic bronchitis or other forms of chronic obstructive pulmonary disease pure oxygen, right? Compressed oxygen, high flow oxygen. It's necessary to give them a low flow rate in order to ensure that they retain the drive to breathe. So here's what could generally happen. Central chemoreceptors are no longer responding appropriately as the levels of CO2 within the body fluids are no longer a good indicator, right, for respiratory rate. And there's a reason why this happens with severe lung disease, like our chronic bronchitis. We see the high levels of partial pressure of CO2. The individual has hypoxemia, hypercapnia. A major problem here comes with the control of acid-base balance. The individual has respiratory acidosis, and that respiratory acidosis can lead to the kidneys attempting to compensate by secreting excess hydrogen ions, making more bicarbonate in order to balance bicarbonate and hydrogen ions within the body. As this is occurring over time, the hydrogen ion concentration will be fairly normal, even though the partial pressure of CO2 is still high and CO2 is still being trapped. So now we lose the hydrogen ions as an important trigger for those central chemoreceptors. And this is what we mean when we say, that the chemoreceptors become desensitized. There is no longer that high hydrogen ion signal to indicate high CO2. Those become decoupled due to this chronic renal compensation for the acid-base imbalance that is occurring. So that reduces the ability of the central chemoreceptors to respond appropriately and trigger ventilation when ventilation is necessary. So now the respiratory drive switches to monitoring oxygen. But the problem then with treating individuals with high flow oxygen to make sure that their tissues are not hypoxic, given that they do have a respiratory disorder and they have problems with exchange, allowing CO2 to leave the body, diffuse out, and oxygen to diffuse in. With the high flow oxygen, the idea is under pressure, you're increasing the partial pressure of oxygen within the alveolar space, helping to push more into the blood plasma, help to load more onto the hemoglobin. And if the partial pressure of oxygen is within normal range, then those peripheral chemoreceptors will stop responding and stop triggering the dorsal respiratory group to trigger an inspiration. And effectively, the individual loses their drive to ventilate. They just stop breathing. because they have this high flow oxygen. And that's a problem. If an individual is now hypoventilating, that means they're not appropriately moving the air in and out of their lungs. And yes, they're getting high flow oxygen, they're getting the oxygen into their tissues, but they're not getting the CO2 out appropriately. And that could lead to the individual becoming dangerously hypercapnic, dangerously high partial pressure of CO2. So generally what is done is, when possible, the minimal levels of oxygen are provided, just enough so that they are able to perfuse their tissues as appropriately as possible, but still retaining that drive to breathe, enough so that those chemoreceptors are still able to respond and trigger the drive to ventilate. And to know exactly what that level is, the blood gas levels, the partial pressures of CO2 and oxygen within the blood plasma will need to be monitored to determine what the appropriate flow of oxygen is for a given individual. Let's see, Megan asked here, if you have dyspnea, is that why you're told to put your hands on your head to open up your lungs to get more oxygen into your lungs after a workout? It's true that body movements do help with that, and to some extent, physical movements of your muscles do help contribute to triggering your medulla oblongata breathing center to help with your respiratory rate. So I would guess that is probably a handy trick to have, is to be able to position your body in such a way that you're able to take in more air. Keep in mind, as we'll see right now, that there are certain types of reflexes that prevent you from over ventilating, right? From expanding your lungs too much. But a position like that might be useful for opening up more airspace without the problem of potentially over expanding your lungs. I could see that working. So finally, the other factors that influence respiration that we should note would be, number one, we know that you do have some voluntary control over your respiratory rate, right? That's shown here. Your higher brain centers, your cerebral cortex, allows you to have some control over your inspirations and expirations. On top of that, there is interactions between the vasomotor center and your respiratory center. Those interactions mainly are in place to help you maintain blood pressure. And so you have feedback between the vasomotor center, the respiratory center, to ensure that blood pressure remains within normal range. And along with that blood pressure remaining in normal range, that means that we're matching our perfusion with our ventilation more appropriately. Body temperature can have an effect on your respiratory rate, mainly an indirect effect in that an increase in body temperature means that you have an increase in metabolic rate, increase in CO2 production, and that increase in CO2 production will then have a direct effect on the respiratory center, right, via the increase in hydrogen ion production. And that can increase the rate and depth of breathing. There are stretch receptors that are found within the smooth muscle of the airways. And these stretch receptors help to inhibit inhalation. Mainly these stretch receptors are informing the pneumotactic center to inhibit inspiration. This is called the Herring-Brewer reflex. It helps prevent overinflation of the lungs. It's generally triggered with really large inhalations. And by inhibiting inspiration, inhibiting the dorsal respiratory group, that will then trigger expiration to occur. There are irritant receptors within your air passageways that will lead to bronchoconstriction in an attempt to stop the flow of those irritants deeper into your air passageways. And these irritant receptors also increase ventilation, mainly tachypnea, fast, shallow breathing to help remove those irritants. And we know anesthesia can have effect on the respiratory center in terms of depressing the signaling both to and from the respiratory center and decreasing rate and depth of ventilation. That's something that needs to be closely monitored when an individual is on anesthesia for any type of surgery, for instance. Let's see, anything else I want to add here? Oh, the point that I made earlier for Megan about stretching the limbs, and the mechanoreceptors are found within the limbs. This image here, even though it's not on our list, right, shows that these types of mechanoreceptors in the muscle and the joints, and even those that are associated with the muscles of respiration themselves, can create changes in the respiratory rate, increasing and decreasing the rate and depth of breathing. With the mechanoreceptors, especially those in the limbs, generally those mechanoreceptors are going to be triggered with an increase in activity, increase in exercise, that will then lead to an increase in ventilation, increase in metabolic, with an increase in metabolic rate. So not only would we have an increase in the partial pressure of CO2, right, leading to the dorsal respiratory group being triggered, but we have these other types of inputs as well that would become important with an increase in metabolic rate.